Yondelis, trabectedin. Mechanism of action. Liposarcoma and leiomyosarcoma are two subtypes of soft tissue sarcoma. STS. Liposarcoma originates in adipose tissue, most often in the lower extremity and retroperitoneum. Leiomyosarcoma occurs in smooth muscle, most often in the uterus and retroperitoneum. Yondelis is an alkylating drug indicated for the treatment of patients with unresectable or metastatic liposarcoma or leiomyosarcoma who have received a prior anthracycline-containing regimen. Trabectedin covalently binds to the minor groove of DNA, which distorts the double helix and causes it to bend toward the major groove. By binding to DNA, trabectedin can affect DNA binding proteins and some transcription factors, including ones directly involved in the oncogenic process. For example, murine xenograft models of myxoid liposarcoma demonstrate that trabectedin induces the displacement of the oncogenic protein fuse CHOP from the promoters of its target genes. In this model and in a human tumor sample, functional inactivation of the fuse CHOP oncogenic chimera was related to a loss of a block in adipocytic differentiation, resulting in adipocyte maturation of tumor cells. Thus, trabectedin's displacement of the oncogenic protein fuse CHOP specifically modulates the transcription of genes involved in the pathogenesis of neoplastic disease. The binding of trabectedin to the minor groove also affects DNA repair pathways, such as transcription-coupled nucleotide excision repair, NER. In vitro studies suggest that trabectedin protrudes from the minor groove and forms a complex with proteins of the nucleotide excision repair system, such as XPG, that ultimately results in DNA double-strand breaks. Experiments in yeast and mammalian cells demonstrate that this transcription-coupled nucleotide excision repair and the resulting double-strand breaks are necessary for trabectedin-induced cytotoxicity. Additional DNA repair pathways, such as homologous recombinant repair, are involved in the repair of double-strand breaks. Cells deficient in the homologous recombinant repair pathway demonstrate significantly increased sensitivity to trabectedin, whereas complementation of defects almost completely reverts sensitivity, suggesting that homologous recombinant repair is a key determinant in repairing trabectedin-induced double-strand break lesions. Thus, increased cytotoxicity and sensitivity to trabectedin is observed in cells with homologous recombinant repair deficiencies with defects in the repair of lethal DNA double-strand breaks. Ultimately, this cascade of events caused by trabectedin binding to the minor groove of DNA can result in DNA damage in the cancer cell and perturbation of the cell cycle, leading to cell cycle arrest and cell death. Indication: Yondelis, trabectedin, is indicated for the treatment of patients with unresectable or metastatic liposarcoma or leiomyosarcoma who received a prior anthracycline-containing regimen. Important safety information. Contraindications: Yondelis, trabectedin, is contraindicated in patients with known severe hypersensitivity, including anaphylaxis, to trabectedin. Warnings and precautions. Neutropenic sepsis, including fatal cases, can occur. In Trial 1, the incidence of grade 3 or 4 neutropenia, based on laboratory values, was 43%, 161 of 378. Median time to the first occurrence of grade 3 or 4 neutropenia was 16 days. Range: 8 days to 9.7 months. Median time to complete resolution of neutropenia was 13 days. Range: 3 days to 2.3 months. Febrile neutropenia, fever greater than or equal to 38.5 degrees centigrade with grade 3 or 4 neutropenia, occurred in 18 patients, 5%. 10 patients, 2.6%, experienced neutropenic sepsis, 5 of whom had febrile neutropenia, which was fatal in 4 patients, 1.1%. Assess neutrophil count prior to administration of each dose of Yondelis and periodically throughout the treatment cycle. Withhold Yondelis for neutrophil counts of less than 1,500 cells per microliter on the day of dosing. Permanently reduce the dose of Yondelis for life-threatening or prolonged severe neutropenia in the preceding cycle. Rhabdomyolysis. Yondelis can cause rhabdomyolysis and musculoskeletal toxicity. In Trial 1, rhabdomyolysis leading to death occurred in 0.8% of the 378 patients. Elevations in creatine phosphokinase, CPK, occurred in 122, 32% of the 378 patients receiving Yondelis, including grade 3 or 4 CPK elevation in 24 patients, 6%, compared to 15, 9% of the 172 patients receiving dacarbazine with any CPK elevation, including one patient, 0.6%, with grade 3 CPK elevation. Among the 24 patients receiving Yondelis with grade 3 or 4 CPK elevation, renal failure occurred in 11 patients, 2.9%. Rhabdomyolysis with the complication of renal failure occurred in 4 of these 11 patients, 1.1%. Median time to first occurrence of grade 3 or 4 CPK elevations was 2 months, range 1 to 11.5 months. Median time to complete resolution was 14 days, range 5 days to 1 month. Assess CPK levels prior to each administration of Yondelis. Withhold Yondelis for serum CPK levels more than 2.5 times the upper limit of normal. Permanently discontinue Yondelis for rhabdomyolysis. Hepatotoxicity, including hepatic failure, can occur. Patients with serum bilirubin levels above the upper limit of normal, or AST or ALT levels, greater than 2.5 times ULN, were not enrolled in Trial 1. In Trial 1, the incidence of grade 3 to 4 elevated liver function tests, defined as elevations in ALT, AST, total bilirubin, or alkaline phosphatase, was 35%, 134 of 378. Median time to development of grade 3 to 4 elevation in ALT or AST was 29 days, range 3 days to 11.5 months. Of the 134 patients with grade 3 to 4 elevations in LFTs, 114, 85%, experienced complete resolution with the median time to complete resolution of 13 days, range 4 days to 4.4 months. In Trial 1, the incidence of drug-induced liver injury, defined as concurrent elevation in ALT or AST of more than 3 times the upper limit of normal, alkaline phosphatase less than 2 times the upper limit of normal, and total bilirubin at least 2 times the upper limit of normal, was 1.3%. 5 of 378. ALT or AST elevation greater than 8 times the ULN occurred in 18%, 67 of 378 of patients. Assess LFTs prior to each administration of Yondelis. Manage elevated LFTs with treatment interruption, dose reduction, or permanent discontinuation based on severity and duration of LFT abnormality. Cardiomyopathy, including cardiac failure, congestive heart failure, ejection fraction decreased, diastolic dysfunction, or right ventricular dysfunction can occur. In Trial 1, patients with a history of New York Heart Association Class 2 to 4 heart failure or abnormal left ventricular ejection fraction, LVEF, at baseline were ineligible. In Trial 1, cardiomyopathy occurred in 23 patients, 6%, receiving Yondelis, and in 4 patients, 2.3%, receiving dacarbazine. Grade 3 or 4 cardiomyopathy occurred in 15 patients, 4% receiving Yondelis, and 2 patients, 1.2%, receiving dacarbazine. Cardiomyopathy leading to death occurred in 1 patient, 0.3%, receiving Yondelis, and in none of the patients receiving dacarbazine. The median time to development of grade 3 or 4 cardiomyopathy in patients receiving Yondelis was 5.3 months, range 26 days to 15.3 months. Assess left ventricular ejection fraction, LVEF, by echocardiogram or multigated acquisition, MUGA scan, before initiation of Yondelis, and at 2 to 3 month intervals thereafter, until Yondelis is discontinued. Withhold Yondelis for LVEF below lower limit of normal. Permanently discontinue Yondelis for symptomatic cardiomyopathy or persistent left ventricular dysfunction that does not recover to lower limit of normal within 3 weeks. Extravasation resulting in tissue necrosis. Extravasation of Yondelis resulting in tissue necrosis requiring debridement can occur. Evidence of tissue necrosis can occur more than 1 week after the extravasation. There is no specific antidote for extravasation of Yondelis. Administer Yondelis through a central venous line. Embryo fetal toxicity. Based on its mechanism of action, Yondelis can cause fetal harm when administered to a pregnant woman. Advise females of reproductive potential to use effective contraception during therapy and for at least 2 months after the last dose of Yondelis. Advise males with female partners of reproductive potential to use effective contraception during therapy and for at least 5 months after the last dose of Yondelis. Adverse reactions. The most common, greater or equal to 20%, adverse reactions are nausea, 75%, fatigue, 69%, vomiting, 46%, constipation, 37%, decreased appetite, 37%, diarrhea, 35%, peripheral edema, 28%, dyspnea, 25%, headache, 25%. The most common, greater than or equal to 5%, grades 3 to 4 laboratory abnormalities are neutropenia, 43%, increased ALT, 31%, thrombocytopenia, 21%, anemia, 19%, increased AST, 17%, and increased creatine phosphokinase, 6.4%. Drug interactions. Effective cytochrome CYP3A inhibitors. Avoid use of strong CYP3A inhibitors. For example, oral ketoconazole, itraconazole, posaconazole, voriconazole, clarithromycin, telithromycin, indinavir, lopinavir, ritonavir, boceprevir, nelfinavir, saquinavir, telaprevir, nefazodone, conivaptan in patients taking Yondelis. Avoid taking grapefruit or grapefruit juice. If a strong CYP3A inhibitor for short-term use, that is, less than 14 days, must be used, administer the strong CYP3A inhibitor 1 week after the Yondelis infusion, and discontinue it the day prior to the next Yondelis infusion. Effective cytochrome CYP3A inducers. Avoid administering strong CYP3A inducers, for example, rifampin, phenobarbital, St. John's wort, to patients who are taking Yondelis. Please see accompanying full prescribing information for Yondelis. Yondelis is an alkylating drug indicated for the treatment of patients with unresectable or metastatic liposarcoma or leiomyosarcoma who have received a prior anthracycline-containing regimen.